We're here to talk about intercultural immersion in Ghana today, and we have some students who have been to Ghana. They're going to talk to you about their experience. I just want to say at the top, for everything IPEC related for the rest of the semester is going to happen in this room. If it says on the calendar it's WCHP, it's lying to you at this point, because we have such great turnout that we had to turn people away in WCHP, and we don't want to do that. So when in doubt, come here, because look at how many of you there are. It's fabulous. So without further ado, Ghana.
Thank you.
Afternoon, everybody. My name is James Walrath. I'm a third-year physical therapy student.
And I'm Leanne Vogel. I'm a junior nursing student in the BSN program.
And we're your MCs. No. So we're here just to get everybody started. Behind me, you've got the purposes of the Ghana trip. I feel like beyond really what's on the slide, the reason behind why I think we all went was to really get to know not only what different professions do, not only what it's like to be in a different place at a different time, but to put it all together and to really become closer, not only with the people that we go there with, but the people that we go there to serve. And I really think that that's what I want y'all to come away with today.
I agree. Interprofessionalism is a big piece of this trip, and personally, I was the only undergrad student going, so I got a little nervous. People asked me, "Are you scared?" I'm like, "No, I'm just scared to meet new people," which is not normal for me. But they were all so helpful, and it was awesome having a lot of PT students there because I learned a lot about how we as nurses interact with them.
This is where Ghana is. It's absolutely beautiful. We spend pretty much all of our time on the coast, up against the ocean. Has a lot to do with the local economy, has a lot to do with the types of things that we saw coming into the clinic. So geography is important.
Yeah, we flew into Accra, which is just on the eastern side of that map, and then Sekondi is where we stayed, right, as James said, on the ocean. So.
All right. So pre-departure planning, y'all can read that. I think the biggest part about the pre-departure planning that surprised me was the time and effort that we took to really understand how it was that we needed to change what we thought we were going to do to meet the needs of the people that we were going to be serving. We have the way that we do things here in America. We have the way that our healthcare system works. And a big part of going to Ghana is realizing that that's not the way that everybody does things.
And it does take a lot of mentality to get past that, but you really don't know what to expect until you're there, and I think that's another large benefit of going on this trip.
All right, so like I said, big part about going over there is learning how to work with other professions. I had no idea who Leanne was before we started having our pre-flight meetings. It was all sorts of fun to get to see her in action, to get to see pharmacists in action, to really get a chance to interact with everybody that went.
Yep. For an example, at first doing triage, which we will talk about in a few slides, we would refer patients to the PT, and at first I was just kind of sending them over, go sit over there, someone else will take care of you, but I realized the important part of interprofessionalism is to walk the patient over and explain to any available PT student what I had seen and what my thoughts were on this patient, so that was a great benefit of meeting new people there.
So I think really the gist of this slide is that going to Ghana and coming back, you don't just go back to the way things have always been. You don't just go back to the way that you were. Going to Ghana really changes not only your mentality as far as what you expect out of the healthcare system, what you expect out of your colleagues and being able to talk to them, but what you expect from yourself going forward, and really how you need to meet the needs of other people and how you can best do that. Taking yourself out of something that you're familiar with, aka the United States, and taking what you do and moving it to someplace where you have no idea what people are doing, how they're going to react to what you do, is really an experience that just broadens anybody's horizons. It's
something that gets inside of you. Now that I've been to one third world country, I want to go help everywhere. And it's addicting. It's addicting. It's scary. And scary on the bank account, but and also great thing about the friendships you meet there. I'm friends with probably 10 more people on Facebook than I was before. And I get to talk to them weekly. They're always interested in what we're doing over here in school, and I get to keep up with them and how they're doing, and it's friendships you make for the rest of your life. It's amazing.
All right, so here's a list of everybody that went. As you can see, it's a pretty good-sized group of people. We would have loved to have had more, though. It was a good problem to have, trying to spread everybody out, making sure that we all had enough to do. And again, it seems like a lot of people, but when you're on a plane, and a bus, and a plane, and a bus, and a plane some more, with all these people, it really is nice to have everybody there to talk to and just share experiences with. The more people that go, the more different the experiences are.
I agree.
There we go. So, sort of a rundown of our normal day. It looks like a really early number up there with 5:30 being get up and run. I was not one of those people.
I was.
Don't worry about it.
So there was a variety of people who would wake up early to run or walk, or you could sleep in as late as possible. It's an option.
But it's not dull, as you can see. There's not a lot of just sitting around doing nothing, because why would you want to do that in Ghana? You can do that in the United States. They really do a great job, by they meaning the program directors, of making sure that we are out doing things. We are out in the clinic helping people. We are out in the community getting to experience what Ghana has to offer. So clinical activities, again, that is a long list, and it speaks to the variety of people that we get to have go. And again, just the diverse way that we're able to provide healthcare there is something that I had never even thought about experiencing here in the States.
Yeah, so I guess I'll start with the triage. That's where the patients would first come, which it was kind of the nursing station, I guess you could say, but it changed. And that's where we would do vital signs and try to get to the root of their problem, talk to them about malaria, stuff like that. And then we would refer them either to PT or vision tests, or we did urinalysis testing, stuff like that. We had the healthcare providers who would diagnose them, I guess you could say, and decide what medication they needed. And then we had the wonderful pharmacy that distributed medication.
One of the other interesting things about this is that, true to the nature of interprofessionalism, just because I was a physical therapist doesn't mean all I was doing there was physical therapy. I spent a day in the lab doing malaria testing. I would, help out nurses, help out doctors, just get the discussion going all over the place. Our brave and fearless physical therapy leader over here, Dennis, his famous saying is, "Be flexible," and that is nowhere more true than Ghana. Go with the flow, do whatever is needed of you, and it's more fun that way.
So this is just, this is a picture of our clinic we set up. This is a church. Reverend Ando is the lovely man who gives us this opportunity. And you can see over in the back right-hand corner is the triage, and then the patient waiting area is in the center in the back. Physiotherapy to the left, providers in the center. Pharmacy, which would be very busy at the end of the day, as we all know. They got a lot of people hit in the afternoon. And then some lab and vision tests. So that gives you a good perception of what it would look like.
So my favorite part about this picture is that there are no walls. One of the unique things about the Ghanaian experience that I can't emphasize enough is the ability for me as a physical therapist to walk 2 feet over to the provider station and ask a doctor, "Hey, I've got this patient. This looks funny to me. Do you want to help me out here? Take a look at this." I have yet to see a place in the United States where I can literally walk and talk to a doctor, walk and talk to a pharmacist, walk and talk to a nurse, and get insight on what I don't know anything about. If I know nothing about how Leanne does what she does, she works magic and it's great.
Thank you.
And she's great at what she does, but I bet she's not as good a physical therapist as I'm going to be.
It's true.
So to be able to actually go and talk with people and understand how to talk to people who know more about what they do than you do is a really unique experience, and probably one of my favorite parts of the trip. So, and skipping this one, right?
Yep.
Okay. Go. Oh, physical. They took it out already. All right.
We're going to turn it over to Claudia and Tom from physical therapy.
Yep.
Hey guys.
You can give that to Claudia.
Oh God.
I'm Tom Geltema. I'm a third year PT.
And I'm Claudia Burns. I'm also a third year PT student.
I would like to start by apologizing for not wearing khakis today. It took away the loudness of the shirt, so jeans went better. We're going to talk about physiotherapy, and it's very much your traditional like overuse injuries. What we didn't see in the pictures earlier is a lot of people carry, upwards of 50 to 60 pounds on their head, so there's a lot of neck injuries that way. A lot of overuse. They literally work from sun up to sundown. So when the sun comes up, you see people out. We're out at 6 in the morning running, and people are already out sweeping and getting ready to go to the market, getting ready whatever they're selling. Also, what you'll find interesting is people have like a broomstick and a broom, but they're not connected. People will sweep just bent over. People will pick things up, they'll bend over. But if you see people hanging on the side of the road, they're comfortably in a squat. So we talked a lot about body mechanics and things like that to make sure that people were using their bodies more correctly as they were going through their daily activities. And also we had some wound care, which we're going through now as third year students, but we had some good debriefing on that. And it was just your general like couple cuts, scrapes, and then taking care of it. Click. As physiotherapy, we had 11 students. So we tend to break up a lot more. So we did vision testing, lab, and intake. And one of the ideas after the first day was to have us do more of the blood pressures, the temperatures, and just doing a brief history, just so we could speed things up. Because as 11 people as physical therapists, we could send them, if I had the picture, you could send them over to us, and it just made the clinic work a little bit more smooth and faster. Claudia?
Yeah, I think at the beginning they were a little nervous about having 11 physical therapy students, and they were like, what are we going to do with them? But we were able to have a girl, Christine, who went on the trip last time, was able to come and kind of help be a supervisor, so she was able to take us on field trips and whatnot, which we'll talk about in a second. So it worked out really well. I think we were pretty helpful. They made use of us. So yeah, the collaboration. So since we're such a large group, we got to go on kind of little outings in the community. So we were able to visit three facilities. The one right there in Sekondi was the Western Regional Hospital. It was an outpatient physical therapy clinic. And just, we weren't really doing any treatments, but we just kind of learned how they do physical therapy there. And it's a lot different, For us, it's very scheduled and like, okay, Tom, your appointment's at 4 o'clock on Tuesday. If you're not there at 4:05, I'm angry and I might cancel you. There, it was like, come on Tuesday and do your physical therapy. And their families were very, very involved. When we went there, I think we saw the physical therapists were kind of walking around helping, but it was basically the patients and their families going through doing their treatment. So it was really interesting to see that. We also went to, I guess it was Central Regional Hospital, which was it was connected to a hospital and outpatient clinic, where we got to do some treatments, and that was really, really nice to be able to see. We had a great guide to physiotherapy in Ghana. His name is Isaac. Learned so much from him. He gave us a tour. Very excited guy, very good physical therapist, taught us a whole lot. So he actually used to work there, so yeah.
One story about Isaac too is, as a physical therapist, you get used to your schedule, so you're going to have a couple evals, you're going to do your treatments, so you might see 10 to 15 people. He said that, a week, he saw almost 100 people a day, and he'd have 15 minutes to spend with them, and that was it, and then he would pass them off, or their family would take over. It's just unbelievable to process, to deal with that many patients in one day.
And they only work till 1, 8 to 1. 100, I can't. Okay, so the other place that we saw was, we went to University Cape Coast Hospital, which actually doesn't have a physiotherapy department now, but they're trying, they've done a lot of research and, proving that physiotherapy is what they call it over there, so I'm going to interchange, sorry. So they were trying to get a program started, and one of the things that we were able to do is donate a lot of equipment, so crutches, braces, wheelchairs, to that program and help them kind of get on their feet. And it was really interesting to see them talk about, they're advocating right now for physical therapy, and we do it all the time here, and it was kind of crazy to see that they're still fighting for it, and it kind of reinvigorated me. we're so important. Okay, sorry, I'm rambling. I'm good. Okay, so a couple of the challenges that we faced there, one of them was, the first thing people probably think would be language. And it was a little bit, but English is the primary language of Ghana. So a lot of people spoke at least a little bit of English. There were a lot of people who didn't speak enough, and or to talk to them. So we had a translator, they were really wonderful. So it really wasn't that bad. We all had fun learning the language. And if you want to know some, you can come talk to me later, because my pronunciation isn't great. Anyway, so yeah. I thought a big challenge, another one that I saw was, it kind of hit home that as physical therapists, we deal a lot with function and how people's impairments affect their lives. And it took me probably to my first patient till I realized that I know a lot about Americans' lives and like what their day-to-day is. For example, laundry. I know that if you need to do laundry in America, you need to like hold a basket, maybe like walk downstairs and like do this motion. Laundry in Ghana is like this. Oh, the camera. There's like this, and you're like washing like that. So it was, if you have a back issue, I'm not going to say, do you have problems doing laundry? But Isaac sat down on an eval with me and was able to ask that question, and I was like, whoa. So he was really helpful in understanding just the day-to-day activities and what people are going to have problems with. Also, cooking, like this woman, that woman is cooking right now. She's pounding fufu, which is a beloved traditional dish of Ghana, and we had some, and it was delicious. But it's basically like pounding with a huge heavy mallet, so that could take some toll on your shoulders for sure. And this woman here is stirring a soup, so just the body mechanics in that is kind of intense. Sleeping conditions, so a big, are you sleeping well? Are you getting enough sleep to heal all your wounds? And it's a big proponent of healing. And some people, you tell your story, I like that one.
James and I had a patient with a pretty bad back, and we're going through all these exercises that she could do in her bed, and about 5 minutes into us explaining this, we were like, wait, do you have a bed? And she didn't. So she slept on the floor. So we had to talk to her son and come up with some good ways to help her get on and off the floor or in and out of what would be considered her bed. So
very different. Yeah, the other thing, so traditionally, when we think of outpatient, which is kind of what this was simulating, people are coming to us. We have, our first eval, which is like an hour long, and then we give them all their exercise, and they come back again and again and again. This time, it was much different because they come in once. Maybe you'll see them again. Most often, this is their one time. And one of the things you really don't want to do is overwhelm someone with a lot of stretches, especially when they've never stretched in their life. They don't know what stretching, like what is stretching? And so you wanted to make it something that they would incorporate into their day, but that they could continue to do. Like you had to pick, like prioritizing was a big thing. And we ended up taking a lot of booklets over, these really comprehensive booklets, wonderful. Christine made them, I think, last time they were there. And we were able to hand them out and kind of, tell them what they should be doing. They love the booklets. We couldn't give them away fast enough. The people were asking for them at the end of the time, so.
All right. There's one other patient that Jamie, Keith, and I worked with, and we went through this whole eval, and something wasn't adding up. And Jamie ended up checking to see for a leg length discrepancy, and it was close to about, I want to say, a little over 2 inches. It was pretty drastic. The history basically was my hip hurts after having birth. So we went through, every hip test, back test, leg test, and we just ended up with that one. And talking about interprofessionalism and just how the clinic was set up, I literally went over to the doctor, gave him the most professional tap on the shoulder, and was like, can you come here and look at this? And he listened to me as I walked all the way up the stairs, because we were in a back corner, and he listened to everything that I was saying, and I was telling him all the tests that we had done. And he asked me, he's like, well, what do you think? And I was like, well, I think something's wrong with the hip, and we should probably get an x-ray. So he went in, did a couple of his tests, and sure enough, he got a script for it, gave her an x-ray, and then she came back, and she had avascular necrosis. So, her hip was just broken, and that's why she had the 2-inch leg discrepancy.
Yeah, and another story that I kind of came up with, James came up to me at one point. I had done some wound care in my first clinical, and a lot of us hadn't. So there was a patient, James said, I got this guy with some wounds. Can you come over and help me take a look at him? Sure. So there's this gentleman sitting and on the chair, and he had some not too bad, superficial, but they looked kind of infected. So I said, okay, let's get him up on the table. Extreme pain, very, very hard for him to transfer up onto this rickety old table. So I'm basically blind as I'm thinking about this wound. And yeah, he has the hip pain, okay. Chris comes over and is over my shoulder going, poking his leg, looking at it. Walks over to the doctors and says, hey, come here, similar situation. The doctor comes over, asks him a few questions, looks at his legs, looks at me, and goes, stop moving his leg. He has a broken femur. And I said, oh. Okay then, he said, these wounds are the least of his problems. But it was really, I never would have thought of that, and the fact that we were able to just, again, pull him right from the treatment, and we sent off to, he was in a car wreck 3 days before, and was just limping around, and it's kind of insane what these people live with for as long as they do before they seek treatment, or their access to treatment is so severely limited that they came in with things that they'd been dealing with for 2 months that I wouldn't deal with for 2 days. So they're very humble people, very, very, very thankful, very, very welcoming. It was great. Anyway, so,
And here's the laboratory. You guys won't really get the joke, but so in the lab, we do a numerous amounts of tests, but the big one was malaria testing, and supposedly everybody can do it. Well, after I may have poked a hole in everybody in Ghana, I think I finally got one. So I just want to let everybody know that if you need training on this, anybody that wants to go, come talk to me. I'll train you well. Everybody will be able to do it.
He knows a lot of ways to do it wrong, so.
And now we'd like to pass it off to Erin from Pharmacy.
Pharmacy.
So good afternoon, and thank you very much to our colleagues from Physiotherapy. Yes, there were a lot of you, but it was absolutely wonderful. I can't say it enough to have so many students and so many students from your department there to spread out and to work with us in a variety of settings. As you said, we were in the pharmacy, which is probably one of the busier corners of the clinic area. We seem to have a mass going on at all times. We started out when we got in, setting up with our supplies. For that, we had a great team. We are very fortunate to be joined by a student pharmacist, Mitchell Chan, who is the first pharmacy student from UNE to go over there with this program. So not only did we get to go as 2 of the pharmacy staff members or faculty members, we also got to bring a student for the first time, which is something we'd hope to expand going forward because there's definitely a huge role for us there. Fortunately, we had 2 pharmacy students in training, if you will. 2 of our public health students, Master in Public Health students, Ta and Stephanie, also jumped in, joined us. They said, well, we're not pharmacists, but train us, we will jump in and do this, and they did. They did an astounding job. They were very, very dedicated to our patients. So I can't thank them enough. And then I was joined by Sarah Smith, one of our other faculty members in the College of Pharmacy, to join me. So it was an amazing adventure. It was a great team to work with. And when we were really short on hands, everyone jumped in. Everyone from our physical therapy students to our nursing students, everyone would come over when we were swamped at the end and say, what can we do to help you guys? Which was just really, again, a huge tie and a huge testament to the interprofessionalism that went on there. Going on to a little bit of a background and thought with this, we had a kind of a diagram when we started talking about this presentation, what we'd like to show. And it's similar to what we have here, but even more so there, that pharmacists could be the link between medication use, patients, and the prescribers of those therapies, whether the prescribers be nurse practitioners, whether they be physicians, whether they be American prescribers that were coming over with us, or whether they're Ghanaian doctors that we were able to work with while we were there. We got to be a link, and that was a really important link we felt in terms of helping with the safe and effective treatment for these patients. We struggled with language barriers, but we were very fortunate to be working with our community health workers on site. Those were Ghanaian locals who helped as translators as well as cultural brokers for us. They're the ones who kind of pointed out things like, does the patient have a bed? Have you thought about how the patient does their laundry? They brought all these things to light for us in a very, very open manner. They let us ask them anything, so we could really get a good sense of what they needed from us. And they would also help us, again, do that brokerage with any patient we were seeing. We were trying to figure out, well, how can they time their medicines? What can they remember? How can we teach them how to safely use their therapies? So we helped with a bridge for this. Also, when it came to safe medication, we went in, we started off by setting everything up. We had some donations from this country as well as being able to access medications from the pharmacy there, and Sarah will tell you more about that in a moment. We set up shop, and essentially just got busy very quickly, and everything was a whirlwind in terms of being busy. And so medication safety became a very big issue for us there, and that's something that we're going to continue to pursue in future ventures there. And that goes back to working with our prescribers and working with our other team members who will join us. With that, I'm going to turn over to Sarah Smith, who will then turn over to Mitchell.
Thanks, I'll take your clicker. Thanks. All right. So I'm going to talk a little bit about medication distribution in Ghana and kind of build upon what Erin was just talking about in terms of how we actually ran business in the clinic. So basically, we did bring some medications with us. A lot of them were over-the-counter medications, and we did get a significant donation from Walgreens in Maine, and we do thank them for that. We also got the bulk of our medications from a local chemist shop that was in Sekondi. And I'm going to talk a little bit more about that when I get to the next slide. So most of the medications that were what we consider prescription medications, we got from the local chemist. So some of the differences that were very obvious when we got to Ghana is that a lot of the medications that they can get in the pharmacy that we wouldn't get over the counter were actually over-the-counter medications. For example, antimalarials were all over-the-counter medications, deworming medications. Those are both frequently used in Ghana, and it was something that I think for me was kind of like, whoa, okay, they can go to the pharmacy and buy these things, which is not normal for us as Americans. Most things that we have, antibiotics, different steroid creams, et cetera, we have to get a prescription from a provider to go in there into the pharmacy and get it from a pharmacist. So that was one major difference, is over-the-counter status versus prescription status. Obviously, we have a lot of variance in the types and names and costs of medications from what we think of in the United States comparatively to Ghana. One example that I can think of is antibiotics. We have very similar antibiotics, but their names are just a little bit slightly different. So when a prescriber is talking to us about, oh, do you have Comoxil or coclavulanate, and we're like, okay, what is that, Augmentin? We don't know. So that was kind of one thing that we were having to get used to, and we used a lot of our resources in order to get that down. One thing we do want to work on in the future is having a formulary for the clinic, because we were very limited on what we had available. A lot of the prescribers would ask us, well, do you have this? And we would say, no, we went to the pharmacy already today, and here's what we have. If you need an antibiotic for a pelvic infection, this is what we have available. And of course, we're limited in our supplies and what we had in terms of pain relievers, antibiotics, antifungals, antimalarials. We were all very limited on that. And I think one of the things we had issues with is communicating with the prescribers what we had versus what they wanted. So this is kind of a little collage that I put together, giving a couple of pictures or insights into what the pharmacy looked like inside that we got all of our medications from. Because honestly, I wasn't sure what to expect when we got there. We got in and it was beautiful. The two pictures up on the upper left-hand corner and upper right are taken directly of the actual counter in the pharmacy in Ghana. And it's actually like very nice mahogany wood with a glass little viewing box, and he had an amazing register. I don't have a good picture of that, but it was one of those old school registers. It was really neat. So some of the things, obviously, I didn't get close-ups on what was on the shelves, but there's a lot available that a regular patient, can come in and purchase after they consult with a pharmacist. So some of the things on the bottom are a lot of topical things. We have benzyl benzoate, which is used topically for scabies, which was something we weren't familiar with, as well as Whitfield's ointment, which is used very often in Africa for a topical antifungal. The next to that is liquid paraffin, which is essentially wax, which is something that kind of caught me off guard. It's kind of a personal story that I had. I had a woman who was actually having a lot of constipation, and what we had available, all we had available was liquid paraffin. For me, I think paraffin, okay, we as Americans, we dip our hands in that, and it's not something I would consume. And actually, it's funny, I'm teaching the constipation lecture in self-care tomorrow, and I'm looking at it, and the closest thing we have in comparison is mineral oil. And we generally don't recommend taking mineral oil, because in America, we have a lot of other safer alternatives. So I had to recommend to this lady how to take liquid paraffin, and it was like, wow, this is totally going against what I've learned in my schooling.
So the next to that is albendazole, which is a dewormer for intestinal worms that we did dispense an awful lot of. And up in the top is Lonart tablets, which are, I had to write this down because this is a drug that I wasn't familiar with until I went to Ghana. It's an artemisinin combination therapy for multi-drug resistant malaria. So we don't really have them in the United States. We think of like quinine-based products, but in Ghana, there's so much multi-drug resistance to malaria that they use artemisinin-based therapies. And then this is just a quick slide talking about how we interacted very frequently with the local providers and how we had differences in what we thought of in terms of therapies versus what they think of as therapies. And we actually had some really good dinner conversations with the Ghanaian providers discussing kind of, you know, what are your first line treatments for hypertension versus our first line treatments for hypertension? Because there were times where they were like, well, why don't you guys have this and why don't you have that? So we got to work with them and understand the variances in their Ghanaian health system and their essential drugs that they consider to be like absolutely essential for a pharmacy to have. So we're gonna keep working with them and work on coming up with a formulary for the clinic and hopefully getting on the ball with that. But they were fabulous to work with. I'm gonna hand it over to Mitch.
All right, so CHWs, we use that word a lot, and CHW stands for Community Health Worker. Community health workers are individuals from the community, the local community that we were at, that we employ, and we actually give them basic education on everything medical, what they need to do in the clinic, kind of like the logistics and procedures of what we do. And so we're really kind of encouraging the community members to get involved, and this is what they've been doing. So they really were the fundamental part of what we did in the clinic. Without them, we couldn't have done a single thing. The CHWs were everything from our personal escorts into the village because we had no idea where we were going, through the markets just to make sure we weren't paying too much for our shirts, awesome shirts here, as you saw. So also the biggest thing though is in the clinic, obviously we don't speak the local language, and so there's multiple dialects in Ghana as well, and so the CHWs really helped us with that, being able to communicate to the patients, because we can't do our jobs if we can't communicate. So for some socioeconomic resources, it's kind of interesting because as pharmacists and as pharmacy students, interns, whoever you are, we always think, especially in America, you go to a CVS or a Walgreens and you get your suspension or you get your medication. They tell you, take this with a full glass of water or put this in the refrigerator after you open it. And we have to start thinking twice about that though, because they don't have refrigerators. And when you tell them to take something with water, you gotta think about, well, is that water safe? If you're taking a dewormer with water filled with worms, it's kind of a problem, right? So that was kind of something. You gotta have to think about that. And also, as I said before, language was huge. A lot of people did speak English, especially the CHWs, but the community members and the people that came to our clinic, a lot of them had no idea what we were saying. So it was great to have them there to properly communicate that. And also, it's kind of a learning experience for the students and also for all of us in general, because when you're talking to the CHWs, even though they are the local villagers and they actually speak English, you gotta understand they don't know what ciprofloxacin is or what diaphoresis means. And you really kind of have to put it in a way that they understand it so they can put it in a way that they understand it. So you're kind of translating it twice. And so it really posed that type of challenge for us, but it was a great experience, and it was a really humbling experience as well. Some of the local traditions there were cuisine, and that was probably my favorite. I love to eat. I'm surprised I'm not 200 pounds right now. That fufu stuff, I liked it.
I didn't like it.
Yeah, it was pretty good. So, but the red, yeah. We're just throwing all these names out. You guys have no idea what we're talking about. But it's all this local tradition food, and it's really great. And the thing is that you got to understand about the patients that come in. What are they eating? What are they eating on a daily basis? What are they not eating? And so when you're giving someone antibiotics, when you're giving someone antacids, And you got to start thinking about these type of things too, because a lot of medications will require you to take it with food, will require you to not take it with food. And also with local traditions, I mean, do they eat a lot of leafy green vegetables? You know, got to think about that too. And so it was really interesting to see what they ate, especially since we're near the coast. They ate a lot of fish, and the fish came from the water, and the water really wasn't all that great. So we kind of had to start thinking about, you know, public health-wise too. But anyways, so another thing about local traditions was the religion. I don't know, I came to Ghana thinking that, you know, it was kind of homogenous in a way, you know, it was maybe just one religion. I've been to Rwanda, and it was a little bit different, but when you got to Ghana, you're able to see multiple types of religions there. You see mosques, you see Methodist churches, you see all different types of churches, and they all live together in harmony, which is really great, which I've never really seen before in the entire world. And what was actually really cool was that, you know, 5 o'clock in the morning, and you think that's early. Well, some of the people, they woke up at 3 o'clock in the morning, and you'd hear them banging drums and pots outside, running down the street, because Ramadan? Yeah, Ramadan ended. And so there was, there was parades through the streets, and that was really interesting because I've never seen that before in my entire life. And so that was really great to see that. And also, just kind of a side note on that was they were fasting. And so for some of us like pharmacy, we talked about diabetes and your blood glucose. So just kind of think about what that does to your body when you're fasting and what you have to take into consideration. So it's kind of like you're not just treating a condition or disease, you're really treating a person. And that person is multidimensional. Some more take-home points. So the biggest thing I saw was long-term concerns. So the need for non-pharmacologic treatments was a must, and it's something that I definitely want to start working on for the next trip. And if you think about it, medicine is only a Band-Aid, and the real way to cure or the real way to be healthy is to change your lifestyle, figure out what you're going to eat and if it's good for you or not. And there's so many ways, especially as you talk to the DPTs. I came in there thinking, oh yeah, drugs, pharmacy, drugs. And so, just like that. And so I'm with James, I'm with everybody here, and I started thinking about things differently because before this trip, I've never known a DPT student before, except for maybe James. And so, that kind of put a different perspective into how I treat patients and how I view the patients. Because if you think about it, if you give them NSAIDs for their pain, that's just putting a Band-Aid on it. But they actually have a broken femur. So, so they actually did have a broken femur. So those are the type of things that I started thinking about, was that just because I go to school and I learn about medicine and how it affects the body and all that, it's not really how you should treat the patient, and that's not how you should view the patient. The patient is very multidimensional. The need for infrastructure is actually very important. I've worked in South America as well, and that was really interesting to see how I could possibly use that same thing I learned down there up here over in Ghana, because if you think about it, as I was saying with water before, if you don't have clean water, you're really not doing much. And so you can only give them so many medicines to cure what they have at that moment. So infrastructure includes maybe a public health infrastructure that supported maybe a new way to get their clean water supply. And right now, they actually did not have clean water supply. And malaria was actually an interesting one. We talked about that a little bit with testing, and one of us had a little issue with doing testings. But malaria was really interesting because we actually had some students from University of Cape Coast. They're medical students in Ghana, and they came over and they did a presentation, and one of it, they talked about malaria. And for them, malaria, over here in the United States, we're like, oh my gosh, malaria, you're gonna die. But over there, they're like, oh yeah, I get malaria. It's nonchalant, maybe it's like a flu, maybe a cold. But for them, it's different, because over here we think malaria is almost like a death sentence. It's so, bizarre for us, and it's a tragic, thing to have. But over there, sometimes people respond differently to malaria, and so one of the students said, well, when I get malaria, I just only have it's like a really bad flu. And so it's kind of interesting to see that, and especially being on the coastline, you have a lot of standing water, and I don't know if you saw it from the pictures, but the sewage goes on the sides of the street, and we actually saw a guy fall in there once, and I think someone lost their glasses in there. Was it you? Gina? Yeah, Gina lost her sunglasses in the sewers. That did not come back home with us. So, So that was really interesting to see kind of how malaria was affecting individuals over there and how different it was on the outlook of malaria compared to here in the United States. And I will hand it over to Jen.
Thanks, and thanks for the students for giving such student context to our experience. It's really validating. Insurance enrollment is something that has been in place for about 4 years now. There's been actually a national health insurance in Ghana since 2004, but in the Sekondi region, we started seeing this come to fruition about 4 years ago. And part of the shift of what we do with our program is rather than focus on treating acute conditions, it will treat acute conditions if it warrants it, but will enroll patients in insurance so that there's a long-term benefit, so it's more longitudinal for them. And what we're finding, we've been doing this for about 4 years now, what we're finding is we are developing a client list so that they're coming back year after year. And this is really a partnership with the Ghana Health Service. We've been working very closely with them. We vetted this through them. They approved this. We wouldn't do this unless it was vetted through the health service. And so this particular experience, so when you heard that there were 11 physiotherapy students, we originally thought there were going to be 13. Dr. Dennis Layton, right over here, recruited this wonderful group of students, but I was nervous. I was nervous first about providing them with a really terrific learning experience because, you know, clinics need to be balanced, right? You typically have a larger number of nurses and providers than you have physiotherapists. So we needed to have a balanced clinic. And so whenever I find out what my student cohorts are, then I figure out what else I need. And we needed to have a lot more providers coming with us. And we have one provider that from the community that comes with us every year. We weren't able to find anyone internally here at UNE this particular trip, so we recruited our friends from the University of Cape Coast. And this was really the first time that we have worked exclusively with Ghana Health Service physicians. We had 6 physicians that came with us, and there are some pictures up here. Dominic, Abina, Daniel, Pascal, some other names. Anyway, most of them were had finished their training, and actually KK and Ignatius were had been their teachers, and so we had 6 internal, what would be classified as internal medicine physicians working with us, and it was fabulous. It gave the students a whole new vantage point on the health system and the health paradigm. And it gave our pharmacy faculty a whole new vantage point on what might be perceived as overprescribing in this culture, you know, where there isn't the diagnostic testing to really determine what an infection may be. They need to treat everything. So it wasn't unusual for our pharmacy faculty to see 3 antibiotics and an antifungal. And it made us realize that this rich opportunity of having all of these physicians working with us, it will enable us to bring many more than one pharmacy faculty member, because there's no way they would keep up. I wish we had film to show you how busy the pharmacy was. So a little help from our friends at UCC. They loved being with us, and this was an immersion for them too, because they dormed with us, they stayed with us, they ate meals with us, they learned about some of our strange idiosyncrasies, and it was really a wonderful share, an interprofessional, intercultural share. Just some photos here that really speak to the community. The big fish, which everyone refers to in Sekondi, is really a marker for some of the boats. But Sekondi is a wonderful fishing village that on the coast. Some of the smoked fish, that's one of the main things that you see in the market. A lot artisans set up shop. And one thing that we encourage our students to do is visit the markets. They do a wonderful job supporting the economy. I think they did this group did a really terrific job supporting the economy. They also find a way to spend time with the children and really explore the culture. One thing that's really important for this trip, while our primary purpose is to provide students with a learning activity in a health paradigm, it's also very important that they have cultural immersion. And so a number of things we do, a visit to the local, we stay in a church, so the students are very immersed in what would be considered an evangelical Pentecostal religion where we are. We also bring in some local drummers and dancers, and they visit the one of the original slave castles on the coast of Ghana, Elmina Castle, which is a very powerful experience. And I'm going to open it up in a few minutes so that students can actually tell you more about those things. We visit a local national park, which is another wonderful excursion. Soccer, for many of you may know that Ghana has had a very excellent soccer program over the years. They've even beat the United States in many international games. And then local markets as well. And so a couple of photos here on some of the patients that we've seen. And I don't know, Leanne, did you want to talk about? Yeah.
I just wanted to speak to you guys really quick about this little girl in the picture because it's kind of a special story to all of us, I think. She actually came in August 2012 to the clinic. She had clubbing of the fingers, which indicates chronic hypoxia, and it's a kind of a telltale sign of a congenital heart defect. So I believe what the students last summer thought was maybe tetralogy of Fallot, which is a very serious condition that needs to be fixed right away, but her mother said that they just didn't have the means to get that checked out. She actually came back to us this August. Similar symptoms. Some of the people who saw her the year before said she was looking better, but the mother had actually brought her and got some tests done by a pediatrician and a congenital specialist, I believe. So it actually turned out being tricuspid and pulmonary atresia, so 2 of the heart valves were never formed. This caused atrial septal defect, so she was just not really, her heart wasn't working properly. And she came back every day. She warmed our hearts. She made me smile each and every day. She didn't say a lot, but she had these mannerisms that were memorable. So we found out that there were going to be multiple surgeries needed in India, and it would cost over $5,000. And we came to a decision as a team to give the last 1,000 that was needed. So I believe that Dr. Martin has been in contact, and and she's already undergone 1 or 2 of the surgeries. So that's a very special patient, and just a good example of why we do what we do.
She has had the first stage of her surgery and is doing well, and we'll keep you posted. So a very special thanks before I turn this over. Like I said, we can't do any of this without the Ghana Health Service, and we've had the opportunity to work with physicians and nurses all along the way. And many of you recognize our Ghana Health nurses in the center of this picture. They're with us every year. Robert Ando, our host. We've had a relationship with Robert Ando for about 15 years. Between different programs, but the program now really rests here at UNE. And so he's been a gracious host and provided a wonderful infrastructure to house our students and really values that relationship. And also our community health educators. There's a group of them there on the right side of the slide. They're future leaders within the church. They are really incredibly generous with their time. They receive a very nominal wage for what they do, but they're really dedicated to the project. We're really happy to have them. Another special thanks to Tricia Mason, Tricia right here, who is the Director of Service Learning at UNE. She really is the hub of how this gets planned, and we couldn't do this without her. And also the Dean's Office. When we have to change our operations to hire other people, the Dean's Office is the first to support these ventures, and those ventures require money. So we want to thank Karen Pardue, the Associate Dean, and Betsy Francis Connolly, our Dean, for wonderful support of this project. One thing that these students didn't mention is that we had some barriers to getting there this year, and what I find really amazing is that not one of them has even mentioned it, and that is that our flight was canceled on the way over. So we had a flight from Boston to London, and then we were supposed to go from London to Accra. Our flight to London was canceled, and we ended up having to take a flight 24 hours later and didn't arrive in Ghana until Tuesday. So their trip was markedly shortened. And our trip over there was by way of Dubai. And you may not have an atlas in front of you, but for any of you who aren't familiar with where the Arab Emirates is, it's not on the way to Ghana. It's in the other direction. So they were so great. No one ever complained, and they just made the most of it because that's what they do. Hillary Jones is a longtime nurse practitioner who's been with this program. She was our one American provider that was there with us, and you can see her in action there. I think all the students would attest that she is quite an amazing medical professional. Ann Tompkins was supposed to be with us today. She is a lady that had called me about a year ago, had heard about this, and the other really supportive thing that our college does is they actually welcome outside participants who are health professionals because it adds to the richness of the experience for students. When Ann called, she said that she was a newly retired nurse from Bay State Medical Center and that she has done a lot of this and would like to come. Didn't realize till I saw her at the airport that she expressed to me that she was 82 years old. She just retired from Bay State Medical Center, and she was fabulous. She wanted to be with us today, but she has been a 52-year season ticket holder for the Red Sox, and she's got another gig later on today. So, but we loved her. She was amazing. Kathy Vizina, who's with us today, is a local nursing leader. She works for the Hanley Hanley Center for Health Leadership. And she and she's a nurse practitioner by training, and she came along and provided wonderful leadership for us as well. Chris Hill, you heard some of the PT students mention Chris. She's an alum. She's a DPT now that works in the field. She was moved by this experience a few years ago, came back, implemented a project that she has done, and provided wonderful supervision for the students. And Dennis took out the slide, or maybe I had a wonderful slide of Dennis Layton, Dr. Dennis Layton, who has actually, when we talk about 11 students participating in this required a lot of planning on his behalf, and we couldn't have pulled this off without him. Dennis has become a part of the planning infrastructure of this program, and so I think we owe Dennis a round of applause. But I want to open this up to questions because I think questions are important for students. The last thing I want to mention is many of the students are here today, but we had 3 nursing students participate, and we also had 2 MPH students participate. And you saw that on the slides that from the day-to-day operations, the MPH students did a lot of work in the pharmacy, and they also did a lot of work in ensuring patients. One of them, Ta, actually did her MPH practicum, and what she did was she revised our clinic card so that we can actually enter it into a database, enter all the clinic cards into a database and capture epidemiologic data to inform not only what our pharmacy needs are, but what our diagnostic prevalences, and so we can make predictions and understand the types of patients that we're seeing better. But I'm going to open it up to questions now.
And because we're streaming live and we do have some people attending via the computer, you need to speak into the mic.
What can physician assistants do?
We've historically had a lot of participation by PA students. It's been we've been largely attended by PAs, and we absolutely want to continue to support that. When I found out this year that we didn't have PAs, this was the first time that we didn't have any, that's when we did a lot of reaching outside. But PAs that come have historically functioned in a provider role. So when you saw that clinic set up, the center portion where we use a primary care model and have the provider, the interpreter, and the family, they would that piece that comes after intake, where they would do their own assessment, differential diagnosis, make recommendations, and referrals. So PA students have a big role, and I really want to get that participation back. So, yeah. Was that your question, really? Okay.
I have another question for the PAs right over here. How can we get involved, and what are the steps for us to get over there?
Tricia, do you want to talk about that? Okay.
So on the screen right now, you see the website for like a program in Ghana. There you can find a lot of information. We have the application, which you can look at, you can complete there. There's also former blogs of trips past, so you can learn more about the program. There's daily schedules. There's actually quite a bit of information up there. The next trip is actually going to be next August, sort of end of July, early August, and we're hoping it'll be slightly longer than in trips past. And so we take applications on a rolling basis, but around April 1st is when our deadline is, and we'll let you know. We're going to be working with faculty in different departments on the scheduling and determining how to get as much participation as possible in.
And I would add to that, even though we have Ghana Health Service physicians, accreditation bodies in the United States require your oversight to be by U.S. trained either physician or NP or PA. We work with Hillary Jones, who you saw. We also have we've had UNE physicians from COM come before. I'm working with Dr. Dora Mills right now to have a colleague of hers who's also an MPH be able to come and do oversight for our PA students as well as MPH students. So.
The other thing I want to mention too that you can find on our website is scholarship information. Oftentimes students ask, well, how can I make this possible? Because it can be somewhat expensive to go. I do want to say that our sponsor actually of a very generous donation of scholarships is with us today. Mr. Chris Hosford is here. And it's due to his generosity that actually we have quite a bit of scholarships to provide students. I know many of our students that go each year, that scholarship makes it happen for them. So there are funding opportunities to really make it more accessible for you as well. Other questions?
Any other questions? Any questions for the students?
So did you guys find that there are any hip abnormalities or any developmental abnormalities with the way they carry their children?
So, as you said, they carry them on their back with their hips abducted, and they have less incidence of congenital hip deformities, actually. That's the main one. But the burden, I guess, comes on the mother because they carry the child there. So we saw everyone with waist pain. They called it waist pain, low back pain. So I would say it benefits the child and not the mother. Anybody else?
So I'd love to hear more from the students about sort of the takeaway pearls that you got. Not literally, but the pearls of what did you learn? What are the pearls?
So the biggest thing for me was getting to use what I had just learned in clinical and using it with my fellow students who are also still learning, as well as using it with a professor who was, Dennis was in a role as teaching us all the time, but actually getting to work with him and as a colleague. That was great. Also, working with the other providers we had here, with pharmacy, with nursing, and when I was helping with intake, learning how they ask questions, they're asking the same question that I would ask, but in a very different way, and getting a very different answer. And so just learning how to ask questions differently of my patients to be able to learn more about them. I think those were some really good things. And there's a lot more, but can't even list them all right now, so.
All right, so I have something similar. I just get really emotional, I guess, when I talk about this trip because, like, how much it impacts your lives and who you meet. Like, I'm going to cry. That's why I don't want the microphone. You just build so many relationships that are so strong that, like, they're true. They're real. And you'll carry them with you through the rest of your career, like, no doubt. And kind of like Leanne was talking about how you still stay in contact with some of the professionals you met in Ghana, and I mean the professionals that you meet here. I'm from California, so it's a memory that I feel like is bigger than even just coming to school in Maine and meeting these people. It's even deeper than that, and kind of growing with that's something you can take with you and stay in contact, like from Ghana to Maine to everywhere. So it's just something else to add on to that. And I didn't cry too much. Anybody else?
Sorry, I know I hogged it earlier, but so the clinical piece we've been talking a lot about, and while that was something that was, phenomenal, and I learned so much, I think a big takeaway from me was just getting to know the community health workers and the Ghanaian practitioners. I spent a lot of time like at dinner or just on our outings, and I was that really annoying girl who was like, how do you say tree? How do you say road? How do you say goat? And like, I just wanted to learn as much as I could about their culture, because it's so, so different. And I think what I'll always take away from this trip is that, they do things really different. Sounds so lame. But, but we all do it right. There's no right and wrong way. And, they work from 8 to 1, and then they don't do much. We work from 8 to 8, and we both, I don't know. Just the cultural differences was so interesting to me, and just I feel like I gained a lot of perspective, I guess, on the way that I will live and that they live, and it was very, very cool.
I think for me, like if I had to sum it up in a word, it'd be like gratitude. When I was telling my family that, I'm gonna go to Ghana, they're like, who does that? You out of everybody would do that. And I never think of it as a big deal. Like, we're very fortunate here, and you don't think about these things. But when you go over there, you're coming at it, like I come at it very nonchalant, like, yeah, I'm here, let's get to work, let's do this, let's help as many people as we can. And everybody's just so happy that you're there. And they're just so happy to be around you, to talk to you, to get to know you. And as you're talking to them, like, and they just get more and more excited the more you ask them questions, the more that you want to learn about them. And then to top it off, like we did have a little bit of a situation as far as getting there. But so we missed the church, and that was the part that I really wanted to go to, because when I sat here 2 years ago, a lot of people talked about that. So they had a choir practice, and they stayed later. We had a long meeting, and they stayed later, and then they sang for us. And to me, that was just unbelievable. It was one of the best parts of the trip for me. Anybody?
So as we all know the interprofessional thing we took from. We all learned so much from every other profession. But as everybody's alluding to, I feel like when you go over there, you became part of the Ghanaian family. And there's no other feeling to describe. I still have a hard time putting into words to what I can possibly imagine that feels. Well, I felt it, so. But I'm getting like flustered because I can't really explain Ghana. You have to go experience it. And when you go over there, it's just a life-changing experience. You'll meet amazing people that'll go last your lifetime, like Amy said. They will try to get to know you because we're so different than they are, and they just want to understand all of us, and we want to understand all of them. So just being over there and being part of their family was really uplifting.
Yeah, for me, it was pretty much said by all you guys. And as a lot of you know, that I was the only pharmacy student there, so I was kind of lonely when I first got there. And I was like, I don't know anybody. Who is this guy? I don't even know. But it really was, I got a huge part of my experience that was academic too, and learning clinically as well, like doing pediatric augmented dosings. I remember we did that, and that was interesting. But most of all, what I think, majority of what I got from it, what I think is the most valuable part of it, is you learn a sense of humility in yourself. And you come back and you start seeing people differently. You kind of say, every person I meet who's different from me, any person, anyone at all, they enrich your life tenfold, hundredfold. And it's up to you to kind of let that in. And it really changes who you are for the better. And as you could see, every single one of us has a hard time explaining what it really is, and there really isn't a single word or a single sentence to really explain it. You kind of have to go there yourself, find out what it's like, and kind of grow from it.
I just wanted to add one more thing about like the UNE program in general. We were able to meet some of us, a quite colorful character over there who was in Ghana in a different town, doing similar work. They'd set up a clinic. They had a lot of doctors and everything, and just listening to her talk. I mean, it was kind of, they came in once and then they left. And listening to her talk and explain what they were doing and comparing it to our program, I was just very happy to be part of a program that was so sustainable. We come twice a year. We don't just come and swoop in and try to do the American things for the Ghana people. That doesn't make sense. So I think that this program does a really great job of working with the community and just embracing their culture and trying to figure out how we can help the practitioners and therefore help the people, not just coming in and, as one of the practitioners said there, coming in, help me today, what are you going to do tomorrow? I think we do a really good job of helping them tomorrow, and the next day.
I'll just take it from you that way. You won't take it off. Anybody else?
Did you have a question? I did. I was just wondering about if you only see a patient for physical therapy, once, what about follow-up?
Dennis, you want to talk about?
Give that one to Dennis.
Thank you, my neighbor Connie. I left a note in her mailbox this morning. I said, ask this question. So I had the same question, when you go over there and you show them some exercises, does it really matter? So we're in the middle of a research project right now where the guy on the next to last slide, Ben, we hired Ben he's going to visit 20 patients that we saw during the week. And he's going to visit them once a month to see how they're doing and to take an update with them. Are they doing their exercises and things like that? And then hopefully in a year we'll go back, and we did an Oswestry assessment, functional assessment at Input. And we hope to go back in a year and find those 20 patients and do a post test like a year out and see if it did make a difference. And then what the main purpose of that is to see what could we do different that would make it last longer and would have more of an effect. So thank you, Connie, and I'll.
Once again, how do I sign up? I go to the website, I fill out the application, I save my pennies.
And if there are any follow-up questions on how to apply or questions about the trip in general, please feel free to email me or Jen. Our email addresses are right up there. We're happy to talk to you more about it. I'm sure the students would love to talk with you as well. They're a great resource for that student experience and perspective as well. So.
And PA students and DPT students, be in touch with your clinical coordinators sooner rather than later to let them know it's on your radar for planning, okay?
All right, show of hands, who's going? We'll get some takers. All right. Thank you very much. Thanks to all of you.